Medurstand. Understanding medicine.
Professor Aziz-ur-Rehman here. I hope that you watched my earlier video on spirometry. If you have not, I strongly recommend that you should watch that video first and then come here, because this is a kind of a supplement to the previous video, and that is on spirometry, and these are some pulmonary function tests which are not that commonly performed. So I just thought that you should know about these also. If you ever confront with these tests, you should be familiar with the terminology, and you should also know how to interpret them and how to translate them into therapies. These two tests are called DLCO and FeNO, and what do they stand for and what do they offer, I'm going to show you very shortly. Now this is DLCO. This is short of diffusing lung capacity. CO means diffusing lung capacity to carbon dioxide actually. What we want to know is what is the total surface area where gas exchange occurs, and if that surface area is physically intact and is capable of diffusing gases. Of course, we measure with carbon dioxide, but that would also be applicable to oxygen. If diffusing lung capacity to carbon dioxide is affected, that would also mean that oxygen diffusion is also affected. In real practice, we can use carbon dioxide, or we can use carbon monoxide and also helium. Different labs, they use different gases, but whatever gas you use, what we are testing is diffusing capacity of the lung, and the implication would be the same. And the second test is FeNO. This is a relatively recent test. This is the measurement of fractional exhaled nitric oxide. Nitric oxide is present in a very, very low level in our ambient air, so we inhale it and we also exhale it. But if we can measure the fraction of nitric oxide exhaled, and that gives us a very, very useful information, particularly to see if there is any eosinophilic inflammation. So these two tests have unique values, and I think you need to know them well. This is DLCO. What is it? This is actually a pulmonary function test. Let me explain few things. This is the device, and this is the cylinder which contains, depending upon which gas is used, either carbon dioxide or carbon monoxide and helium. Now please note down, carbon dioxide is going to be inhaled, carbon monoxide is also going to be inhaled, but that is usually in extremely small quantities, very small level, as you can expect to give you any harm. And then the clip is applied, patient is given detailed instruction, and this is the instrument, and this pipe goes to the instrument which can measure the whatever gas. For example, you use carbon dioxide, so exhaled air goes to a device which can measure the amount of exhaled air, and that can be calculated and then converted into some readings and into graphs and printouts. So what they do is, patient is first given a training how to perform this test. Patient is usually asked to take normal breath from this. Clip is applied through the mouth. Patient takes normal inspiration and expiration, just normally, quietly, for a few seconds. Then patient is instructed to take a fullest possible inspiration. That can be given, that can be a verbal instruction by the operator, or there may be a computer saying that take deep inspiration. Now patient takes a deepest possible inspiration, and at that particular time a certain amount, a measured, a calculated amount of gas is allowed to go into the inspiration. Okay, so patient actually inhaled a certain amount of gas from this cylinder. and then patient is asked to hold the breath for 10 seconds. Now this is important. Why? Because we have to allow a standard and sufficient time for the gas exchange to occur. Now theory is that air and this gas is inhaled. This goes to the alveoli. Now from the alveoli it will be absorbed, and from it will go to the capillary blood, and in the capillaries we have red blood cells, and the gas, carbon dioxide or oxygen or carbon monoxide or helium, that will bind to RBCs. Okay, so after 10 seconds patient exhales, and the exhaled amount of same gas is measured. So the total amount which was inhaled and minus the one which was exhaled, that is the gas which is retained. And where it is retained, it is not retained in the alveoli. It is not retained in the airways. It is kept by the RBCs. Now, why the RBCs? They could go to the RBCs if they were absorbed. And the gas would be absorbed only if the membrane, if the gas diffused across the membrane. All right. So with all this, we are going to measure how much gas diffuses across the alveolo-capillary membrane. So that is actually the true lung function. So this is the basic physics and basic principle of this test. Indications of DLCO. First of all, diagnosis. In obstructive airway diseases, the primary test is spirometry, and we have FEV1 and FEV1 FVC significantly reduced. And as I told you, in restrictive lung diseases, a pulmonary function test sometimes does not give you the true picture, because that measures the obstruction and the total volumes. The normal spirometry does not measure the diffusion. So to make the diagnosis of interstitial lung disease, this test is great. Okay, so those diseases which specifically or predominantly affect alveolo-capillary structure or the membrane, the surface area, there this test is useful for the diagnosis. Then prognosis. Of course, any disease we want to know how much responsive it is to the treatment and how the patient is doing, whether the patient is improving or not. So this test can be done at baseline, and then after treatment, during the treatment, we can do the same test and see if there is any improvement or not. Then pre-operatively, this is one of the main indication of DLCO. If somebody has to undergo lung resection, there is a tumor in the lung, and surgeon wants to know if patient will be able to tolerate that surgery, because once you remove a certain part of lungs, if the lung behind has limited DLCO, then operation is considered contraindicated. If patient has got a tumor somewhere, and if the remaining lungs are normal, tumor can be taken easily out, and some part of lung can also be taken out. But if the background lung is already affected and there is a reduction in DLCO, this is considered a contraindication for operation. And if patient is fit for operation based on DLCO, then of course after the operation the test will be again repeated to see if there is any change in the DLCO. Causes of reduced DLCO. One is thickened alveolo-capillary membrane. Just imagine any condition where there is interstitial thickening, and one classical example is interstitial fibrosis. There are many causes behind interstitial fibrosis, and just one word will suffice to include all of them. Then sarcoidosis. In sarcoidosis also there is a reduction in DLCO. Now there are actually other conditions, but I will just give you the prototypes. Reduced surface area. In emphysema, what happens is although the total lung volume is increased, because of air trapping, but the actual surface area where exchange of gases occurs, that is reduced because interalveolar septa are destroyed. Numerous small alveoli are converted into one big space or multiple big spaces. So that will increase the total volume but will reduce the surface area. Since diffusing capacity is function of surface area, and then that means in emphysema you can expect DLCO to be reduced. Emphysema has got both component obstruction as well as restriction, so it will have all the abnormalities we expect in obstructive airway disease, and it will also have reduced DLCO. DLCO, for example, in asthma may not be affected. In chronic bronchitis also DLCO may be normal. The third possibility is ventilation perfusion mismatch. Now imagine a lung experiment. Let me give you an experimental condition. If there is an experimental model, and if you ligate right-sided pulmonary artery and left-sided bronchus. Now patient, that animal may have normal pulmonary circulation and normal ventilation, but there is no ventilation perfusion equality because one lung is being perfused, not ventilated. The other lung is ventilated but not perfused. So there will be no effective exchange of gases. Here at a smaller level, imagine pulmonary embolism. If pulmonary embolism has affected one major portion of lung, so that part of the lung is not being perfused because there is a pulmonary embolism, but is still getting ventilated. So that will be actually wasted ventilation. Okay, so that is, there is ventilation but it is wasted. So there will be definitely effect on diffusion of gases. So these are three categories of lung diseases where DLCO may be helpful. Now this is the second of this. This is called FeNO. What is FeNO? FeNO is fractional exhaled nitric oxide. Nitric oxide is present in our ambient air and we normally inhale it, but in a very, very small quantity. With this device, this is the device called inflammometer, because this measures inflammation. Actually, I'm just going to tell you how. And this is the device. Patient exhales into this slowly, gradually at a steady level, and this measures the amount of nitric oxide exhaled. Patient is not given nitric oxide because that is the nitric oxide produced within the body by the eosinophils. So it measures exhaled nitric oxide, and the range may be between 0 to 100. So the range is between 0 to 100 parts per billion. Okay, in that person you are going to measure how much. Value increase in eosinophilic inflammation. Not just any inflammation, in eosinophilic inflammation, which is the hallmark of allergic or atopic asthma. So this will be particularly useful in asthma. Patient with asthma would have increased FeNO. Patient with other airway diseases may not have any change in FeNO, but those who have asthma also is of two types: the eosinophilic asthma or the allergic asthma or the atopic asthma. There will be increased FeNO, and this actually translates into responsiveness to steroid. So it may be useful, it may be useful for the diagnosis, but even if you know that this patient is asthmatic, still this test may be useful because it tells you whether or not patient is likely to respond to inhaled corticosteroids. If somebody has airway inflammation due to eosinophils, that is the person who is likely to respond to inhaled corticosteroids to the best. So if this value is less than 20, that means asthma is unlikely, and response to inhaled corticosteroid is also very unlikely or less. If value is more than 40, it is likely to be asthma, and response to inhaled corticosteroid is likely. So this is how we use this the test. Now it has got prognostic value also. That means if somebody is known case of asthma and is being treated with inhaled corticosteroids, patient is still not still not responding, that means we need to try harder. Maybe patient is not adherent to the treatment, or maybe we need to give systemic steroids, or maybe we have to give high dose of inhaled steroids. So that brings me to the summary of this slide, this short presentation. First of all, DLCO is a useful test and it measures diffusing capacity of lung and is particularly useful in restrictive lung diseases. It will give you the exact value for diagnosis and prognosis, and I told you it has got great value when we planning a resection of the lungs to see if patient can tolerate that procedure or not. FeNO measures eosinophilic inflammation and is particularly useful in determining the responsiveness to inhaled corticosteroid. In chronic bronchitis, there is also inflammation. Those people who smoke, there is also inflammation. But it is less range in those conditions because it specifically measures the inflammation due to eosinophil. Nitric oxide is actually produced by the eosinophils. Now both are useful, but both add information to spirometric values. So unless you already have spirometric readings, you can go straight away for these tests. But I think if you are investigating somebody from the scratch, I think it makes more sense to do spirometry first, and then if needed DLCO and FeNO. So then it will make definitely more sense. So that is my lesson. So this was all, and this was a short video, and this is Professor Aziz-ur-Rehman from Medurstand. I look forward to see you in my next video, which is again going to be on another pulmonary function test. I think in the next video I'm going to cover a very important topic which students find very difficult to interpret, that is arterial blood gases. Thank you.